As we all know, the best technology for safely and accurately placing implants is guided surgery, where a drill guide containing a guide tube is constructed based on 3D imaging and implant planning software. When tube guides work, the results are phenomenal. However, there are problems with the technology, and guided surgery has not been widely adopted, most likely due to technical limitations and cost. I use tube guides on many cases. In response to my experiences with tube guides, I developed the Tubeless ThinLayer guide to address the limitations of tube guides, which we will discuss. We conducted a survey of 12,000 implant dentists in the U.S., and the results of this survey validated my impressions. Today, I would like to discuss some of the issues associated with guided surgery, review our survey results, and introduce a novel 3D-based drill guide system. Tube guides, or any guide that guides a drill trajectory, works in the following way, tube guides. A drill trajectory basically is point A, point B connected by a straight line. In a guide tube, the top surface of the guide tube defines point A, and the bottom defines point B. And both of these are in the same device. And so when you place a drill within the guide tube, it's guided along the chosen trajectory, and that thus an osteotomy is created. With the thin guide, the ThinLayer guide, the upper and lower points of trajectory are defined in sequence. And so initially, an insertion point on the gingiva or bone, can be a bleeding point, it can be a small pilot hole, is created. And then we take a ThinLayer guide, which is analogous to the top of the guide tube, as the other point of the trajectory. And when you connect these 2 points by putting the tip of the drill in the pilot hole and another portion of the drill through the guide tube, you now have a defined trajectory, and you can drill and prepare an osteotomy. And this is quite different from the conventional tube guide. The limitations of tube guides are known by anyone who has used them. As I said before, I'm an advocate of tube guides. They work great. It's just that they don't work great in all the situations we need them to work in. In our survey of 12,000 doctors, we had 875 respondents. They described the limitations of tube guides. And basically, its limitation is you don't have visual and physical access to the surgical site. Oftentimes, many tube guides have a large flange. And the doctors, pretty much all of the doctors, acknowledged they wanted physical and visual access to the surgical site. Another major issue is the need for increased vertical space. 77% were frustrated by the need for clearance. And more interestingly, they noted that in 30% of their cases, they didn't order a guide because of their concerns about vertical clearance. And finally, the cost of the guide and a surgical kit are quite high, and our respondents indicated that these costs were too high to use in 1 to 2 implant cases. And perhaps the most intriguing number was that they indicated 18% of the guides that they have received are discarded at surgery. So first we went after that. We said, why are 18% of guides discarded? And based on the experience that I've had and in speaking to other surgeons, it comes down to, I think, 4 items. One is planning error. Oftentimes, you plan the case virtually, everything looks perfect, and then you come to the mouth, and clinically it just doesn't look right. So sometimes there's a discordance between your virtual plan and actually what you see when you look live in the patient's mouth. Secondly, inadequate vertical space. Sometimes the guides don't fit, poor fit, they rock. And the fact that you can't modify this guide once you have it. If you get to surgery and say, well, I think I'd like the osteotomy a half a millimeter this way or that way, or a millimeter this way or that way, with a tube guide, you cannot change it. Either you go with the trajectory the tube guide gives you, or you can't use the guide. So if we just go look at planning error, what are the issues associated with planning error? Because these guides are based on the plan. It's like a computer. What you put in is what you get out. And in this situation, if the plan is not precise, if it's not accurate relative to the actual patient anatomy, then the drill guide will not be usable. Well, I think one of the issues could be is many plans are based solely on osseous anatomy, where while you're planning the case, you can't see the outline of the gingiva, you can't see the opposing tooth, you can't see adjacent teeth. Secondly, there seems to be a perceptual difficulty looking at 3D images in 2 dimensions. This issue was described to me by the owner of a large digital dental lab, who indicated that they face this problem when designing crowds virtually. And there's a learning curve here in which to overcome this issue, but to be aware of it is very important. And finally, plans based on 3D image with scatter can be a problem. Sometimes critical anatomy is obliterated, or the data merge may not be accurate. So if you have a scan and there's enormous amounts of scatter and you have anatomy that's obliterated, perhaps that's not a case in which to do guided surgery. With Blue Sky Plan and guided surgery solutions, enhanced tools, I think that we are able to reduce the planning error. And these are the tools that would be available in order to do that. The plan is based on merged data, showing the osseous anatomy, gingiva, and teeth. Plans can be based on anatomy of the opposing dentition, anatomy of a temporary or permanent prosthesis, a full denture, or an edentulous ridge. We've also introduced the ability to plan on the basis of reference marks, showing pilot hold entry points that are in ideal anatomical positions. Radiographic stents are usually not needed, and we have a scanning protocol for cases with scatter where we still can obtain accurate merges. This slide illustrates some of the enhanced tools that we have available using Blue Sky Plan. It's an extremely powerful software package and enables us to do what we're showing you. In the top left panel, we can see a cross-section of a mandible with an implant in place. But we also can see the outline of the gingiva. We can see an outline of the opposing tooth. And in this case, you can see where we have the implant lined up, a mandibular molar implant lined up with the lingual cusp of an upper molar, is as it should be. In the center panel, there is an image, a 3D image of an articulated dentition. On the top right panel, we have an image of the edentulous area and the adjacent tooth, and you can see a reference mark. And that's a mark in that model which represents the ideal position for the placement of that implant. We also can use the abutments as virtual teeth. For molars, I usually set them at 10 millimeters. They can be whatever you wish them to be. It could be 9 for a smaller molar, 11 for a larger molar. And so you can look 3D on the actual model and see what the relationship would be between your future tooth and the adjacent teeth. And I think these enhanced tools will go a long way to minimizing planning error. The vertical space issue is one that everyone is familiar with. A tube guide requires you to stack the drill above the tube. The kicker is that we don't always measure the maximum interincisal opening of our patients as part of our pre-surgical plan. And so you have situations where the issue is not appreciated until the surgical appointment, at which point the guide is discarded. But the tube guides can easily add 6, 7, 8, 9 millimeters of vertical height requirement to a case. The Thin Layer Guide addresses these issues by its design. First, we provide a snug-fitting, disposable drill stop. And these are made custom for any drill system that might be used. So the first step would be to use an insert with an endo file or a sharp burr and create a bleeding point. And this replicates the ideal insertion point for the case. So you create a bleeding point. Then the drill, we use a Salvin spear drill, is inserted through the guide. The drill stop engages the guide hole, and you can now create a pilot hole. The tip of the drill goes into the bleeding point or the initial and creates a pilot hole. You then place your 2 millimeter pilot drill, and you insert the drill through the guide hole, but you can do it as an angle. So if you place it at an angle, you now require no more vertical clearance than you would freehand drilling. In other words, if the drill and the handpiece will fit in someone's mouth without a guide, it will fit in their mouth with a thin layer guide. So you drag the tip of the drill along the gingiva, insert it into the pilot hole, and drill to depth, as seen in the lower right panel. This procedure would then be repeated with drills of increasingly large diameters. We advocate that measurement of the patient's vertical opening should be part of the surgical plan, part of the pre-surgical workup, because this dictates whether surgery can be done or it can't be done, or if it can be done, this will dictate the length of your drill and the maximum length of the implant that you can use. And it varies for different drill systems, and it varies depending on the size of the head of your handpiece. So in this is a chart which we have constructed, and it's just a small sample of our database, where we can tell you, if you tell us, in order to use our system, we need you to give us the specs on your handpiece. And we'll measure the handpiece, we'll measure the insertion of the drill into the handpiece, and know precisely the vertical space needed for a given handpiece and a given drill. And in that way, we can tell you that if you use a drill length, in this example, a Blue Sky Bio short of 32.5 millimeters in a specific handpiece, we can say, well, under those circumstances, your maximum implant length is 10 millimeters, say. And so, again, this should be all part of pre-surgical planning. And in my experience, it has not been part of pre-surgical planning. And I think that's why in a number of these cases, the guides are discarded because of lack of vertical clearance, because this was not worked out ahead of time. Finally, I think we all would agree cost is a barrier to adoption. In our survey, a pretty obvious conclusion, but guided surgery would be used much more if it was less expensive. When you look at the cost breakdown of currently available systems, first you have the upfront investment in implant planning software. You have a software annual maintenance charge. You need a guided surgery kit, which is usually proprietary. And then the cost of the guides can range from $300 to $650 and up. Additionally, there are fees for a radiographic stent, oftentimes. If the file has to be merged or cleaned, another charge, and obviously a charge for treatment planning. With the Thin Layer system, it's based on Blue Sky Plan software, which is powerful software, and that's free. There's no annual maintenance, and it works with almost all systems and most drills. You don't need special drills. And the single implant guides are $249, $50 for an additional site, and a charge for planning your case. I think at this point, Michael, if there are any questions, then I think if there are any questions at this point, it might be a good break to answer questions. If not, I'll continue on.
Well, if anybody has any questions, they can be entered into the chat box on the bottom right, and Dr. Haber could address them. Okay, I think we could continue onwards at this point.
Good. All right. So
I'll interrupt you if there are any questions.
Okay. At this point, I think I'll just review the characteristics of the Thin Layer guide system, that it's based on the enhanced Blue Sky Plan planning tools. We need a model and a plan of the case. It's usable in molar sites and in patients with minimal opening. Requires the same vertical clearance as freehand drilling. You have physical and visual access to the surgical site. Works with most implant systems and drills. Custom disposable drill stops are provided, and radiographic stents are usually not needed. I'd like to now go through a series of cases to illustrate how this system is used clinically. We selected cases to basically show how the guide system is used in different parts of the mouth under different circumstances. So why don't we start our first case? This is a lower second molar with flap extension. The first thing we have to do is plan the case. So when you open up Blue Sky Plan, you'll see this screen with your cross-sectional screen, your axial screen, panoramic screen, and the 3D screen. The first thing we recommend in this case is to go to the 3D screen and select the articulated model. What this does for you is it provides the outline of the opposing tooth in your cross-sectional view, as you can see right here. We next would go to the panoramic screen, and here we would size the implant. This is maybe a 5 by 11.5 implant. And then we use the abutment as a virtual tooth. In this case, the abutment was sized at about 10 millimeter diameter. So you can move this into position, and you can see your mesial distal orientation. You can move your abutment against the distal of the tooth, and right off the bat, your implant is in a pretty nice position. We next go to the cross-sectional screen, and here you can see the implant is placed. I can see the outline of the crest, so it gives me some indication right now of how thick the gingiva is over the implant, and that has implications for the vertical placement of the implant. Secondly, the center line of the implant, in this case, was arranged to meet the lingual cusp of the opposing molar, as it should be. And so now the mesial distal orientation of this implant is set quite easily. We then go back to the 3D screen, and we select centered model. The centered model is a 3D image of a model in which there is a reference point, and that reference point is in the ideal location for this implant. For a second molar implant, the entry point would be 6 to 7 millimeters from the distal of the adjacent tooth. And then we can see where the center line of our implant is relative to this ideal position. You may not always be able to get it in the ideal position, but at least you know where you are relative to the ideal position. And this is one way in which you can overcome the looking at 3D in 2D problem, because this is based on the ideal position is based upon a model, which you can see in hand, not on a 3D and 2D. You can also then look at this and use the abutment as a virtual tooth and see quite accurately exactly the relationship between the future tooth and the adjacent tooth. Finally, you can look at the occlusal relationship, and you can see exactly where the center line of the implant will meet the upper molar. And as a final quality control test, you can look at all the views and just check it out to make sure everything is okay, and then this plan can be submitted for fabrication of a drill guide. So now let's look at the first case clinically. It's a lower second molar. What we've done here is we placed the spear drill in a plastic insert in the tube guide and took a film just to illustrate the trajectory of this implant. And here you can see, in this case, we used the tube guide to start. The plastic insert is placed with the spear drill to create a bleeding point. We created a pilot hole. In this case, it was a flap exposure. And one thing I wanted to highlight is that the guide in no way impedes your ability to reflect the flap, or to access the site, or to see the site. This is a lower second molar. Here you can see the drill is inserted at an angle. It's brought upright, engaging the guide hole, and brought to depth. And you can see how the depth stop engages the top of the guide to control depth. When we look at this view, you can see an implant, a surgical analog in place illustrating the position within the guide hole. And we do this sequentially with each drill until you reach the desired diameter of your osteotome. And again, here you can see final drill in place in the center of the guide hole. With a system also, you can use the system with your countersink, your tap, and your implant driver. And as you can see in the top left panel, that's a countersink centered in the guide hole used to countersink the osteotomy. In the top right, the drill stop fits the tap, and so the tap is being used centered in the guide hole. And finally, in the bottom panel, the implant driver is centered in the guide hole to place the implant. And as we'll see in a later case, that can be a very, very critical piece, because in type 3 or type 4 bone, when you're using self-tapping implants, they can find their own way regardless of how the osteotomy was positioned. Finally, we take a look at the finished case. You can see the implant position. And when you go to the bottom panel, you can see that the position of the implant clinically is exactly as it was in the model. Another point I'd like to make is that this system can be used without a drill stop. And I've done this, as you'll see in subsequent cases, many times. So if you prefer to do this, it feels like freehand drilling, but it's guided, because the position of your entry point on the gingival surface is defined, and because the center of the guide hole defines the second point of your trajectory. So it feels like freehand drilling, but in fact, it is guided. In this case is a flapless case, where we placed implants in the upper right posterior segment. The patient was missing teeth number 3, 4, and 5. And on the bottom panel, you can see the ThinLayer guide. And on the right-hand side, this is done a little differently. This is a pilot hole guide. It sits right on the surface of the gingiva with holes to guide the pilot hole drill. So here's the pilot hole guide placed on the patient. We go through each hole with the 2-millimeter drill, and you can see we have our pilot holes, just very shallow little indentations. Next, we go through with our series of drills where the drill is centered in the guide hole, the tip is in the pilot hole, and we drill to depth. We're using the depth markings on the side of the drill. Here you can see the position of the 3 implants with guide pins in place. This was a flapless case, so we used a tissue punch, and we used the guide hole here to allow us some control when we place the implant. This is the finished case, and you can see the position of the implants radiographically and clinically, and the final restoration. And the restoration was very straightforward because the implants were positioned in a rather prosthetically ideal way.
Let me interrupt you with a few questions, if that's okay.
Sure.
The first question that came in is regarding the scanning protocol for the model.
Yeah.
If you could elaborate on that a bit.
Yeah. What we do is we cone beam scan plaster models, and that gives us tremendous flexibility in what we do. And that's how we get the models. So when people send us models, they're cone beam scanned and then merged in with the blue Sky Plan anatomy of the patient with the bone scan.
So is that something that you scan, or is that something that the doctor should have scanned with the patients?
Well, we find that docs who have scanners in their office do it themselves, or if someone sends us a model, we'll scan it for them.
Okay, the next question that came in is asking if the drill guide also acts as a stop for the depth.
Yes, that's exactly what it's designed to do. Yes.
Okay. Another question that came in is if you collaborate on how the surgical guide allows flexibility to modify the surgical plan at the time of surgery.
Yes. In this system, let's say your entry point, let me go back to here. Let's say your entry point, when you open this case, well, this is a closed case, but let's say the entry point is off and you want to move it a millimeter, half a millimeter, one way or the other. What you do is you look at your scan and you see if you do that, how does that affect the trajectory? And you can make an alteration either only in the entry point, or sometimes you can make an alteration in the guide hole. You can put crosshairs on the guide hole. You see these crosshairs here. Let's say you make a mark half a millimeter to this side here, and you move this a half a millimeter this way. You'll have the same trajectory, but you'll slide the implant a little half a millimeter in that direction. So yes, you can have flexibility in, you can change the plan at the time of surgery.
Okay, I think that wraps up the questions for now. If there are more questions, you can enter them into the chat box on the bottom right, and we'll address them as the webinar proceeds.
I mean, in regard to the last question, you're not restricted by a tube. So if you don't like what you see, you can change it. But when you change it, you have to be aware of your cross-sectional view so that the change is compatible with the anatomy of the bone. But I've changed many a trajectory when I didn't like what I saw, and they work out fine. Okay. Next case, tooth number 31. I call this nightmare access. The lower second molar in a patient who did not open very wide. He had significant bone loss on the distal of tooth number 30. So this was a deep site, and his molars were set back in his jaw. So this was a very, very difficult placement. We used a pilot hole guide in this case, and we used a ThinLayer guide. We prepared a pilot hole, and you can see how tight the space was. This poor patient was really cranking to keep his mouth open, so I could barely get in there. And then we did an angled entry, and again, even with the angled entry, it's a squeeze, and then we had him stretch so I could get in vertically. Here you get some sense of the implant placement, the implant position, from the occlusal view and from the buccal. And finally, the case, this is the implant position clinically, and here's the implant position radiographically. I think we all know that there's no way you could do this with a tube guide. So the situation is such that either you do it freehand, or in this case, I was fortunate enough to have this guide. Case 4. This is replacement of upper first and second molars in a patient with a minimal mouth opening. This case was done flapless. This patient opened about 40 millimeters, about 2.5 fingers. The vertical clearance posteriorly was about 30 millimeters. When you start running the math and you look at the drill length was 34.5. The vertical requirement in that particular handpiece was 37.1. Fortunately, maxillary teeth have a buccal cant, as mandibular teeth have a lingual cant. And so I was able to bring the handpiece a little bit to the buccal and still be on line with my trajectory to pick up the extra few millimeters I needed in order to do the case. So we made a pilot hole. I inserted at an angle as seen in the top right panel, swung vertical, and drilled to depth. And you can see the position on the right side through the occlusal view of a guide pin. I used a tissue punch And this was a low-density case. So I enlarged the diameter of the osteotomies using an osteotome. And in the lower left panel, you can see that you can use the osteotome through the guide in order to not distort your trajectory. In the center panel, you can see the position of the osteotomies, and then the implants were inserted through the guide. Again, this is maxillary bone, very easy for a self-tapping implant to get off track. So we use the guide hole for the implant insertion. And here's the completed case, and you can see the views of the implants are in rather ideal position and made for easy restoration.
¿Lo puedo ya tirar o para querer que lo guardemos todo?
No, quítelo, ya tíralo, nada más la pura cucharilla.
If somebody's dialed into the webinar, please mute your phone so it doesn't interfere with the webinar presentation. Let me interrupt you with a few more questions, if that's okay.
Sure.
One question is if the DICOM data from the patient's CT scan needs to be converted. I can, just to address that, the Blue Sky Plan software allows the conversion to be done within the software, it's self-processing, and I'm sure that's something that Dr. Haber and his team could help with if the doctor needs help.
For sure. Actually, Michael, what we do is if we receive the DICOM data from the patient, we'll put it into Blue Sky Plan and merge the files with the stone model file. And what we send back to the doctor is a merged plan. So he can, when he plans the case, he has access to the anatomy, the gingiva, the teeth, as well as the bone data.
So you could really set everything up for the dentist and just give them the case ready for treatment planning?
Yes, pretty much. Yep. Yep.
Another question that came in connected is if a doctor has a case planned with no LayerGuide software, if you're able to help them convert the case to Blue Sky Plan and fabricate a surgical guide.
Not that I know of. Michael, you might better answer that. I don't know. I'm not aware that you can convert from one implant planning software into another.
That's correct. You cannot convert, but if the treatment plan's already done, it shouldn't be too much of a challenge to redo the plan in the Blue Sky Plan software. It should probably just take a few minutes.
I would agree with that.
Okay, those are the questions for now. I think we could continue with the webinar.
Okay, thank you. All right. The fifth case is lower left first and second molars. And in this case, we use a guide to create bleeding points by putting a perio probe through these holes. And again, it's the same principle as we described before. We're defining the trajectory sequentially instead of all at once with a tube. So you have your bleeding points here and here. We use these spear drills for our pilot holes. They're very accurate. They go right through the bleeding point. They don't slip laterally. They just lock onto wherever you put them. You can see the entry points here. We drill pilot holes. Here you can see the pilot hole, 2 millimeter diameter pilot hole. The flap has been reflected. Here are some guide pins to show you trajectories and spacing. The guide is in place. You can see that the osteotomies are in line with the guide holes. Same thing when you put pins in them. You can see how things are centered. Here are the final osteotomies. We're using the cortical drill or the countersink through the guide centered. We're placing the implant through the guide with the driver centered in the guide hole. And here you have placement of your implants. Again, ideal situation for the restorative doc. Okay. Our case number 6. These are implants into the 3, 4, 5 sites. The number 5 is an immediate implant, and we have a sinus graft in the 3, 4 sites. As you can see, we had to cut out this bridge. This was a fractured tooth over here. So here's the case. We had a drill guide with an insert in it, and we put an endo file in and created our 2 bleeding points. So these are our insertion points. We then use the guide, drill through the guide to create our pilot hole, and use subsequent drills to prepare our osteotomies. We then did an osteotome sinus graft through the thin layer guide. And again, the nice thing about that is that the guide maintains the trajectory even when you're using an osteotome. On the upper right panel, you can see the surgical analogs in place. In the lower right panel, you can see the as well as the sinus graft.
Ese no, obviamente, ¿verdad?
Hay que cortarlo.
¿Y ese que traía ella?
In the left panel,
excuse me, please mute your phone. It's interfering with the webinar.
Entonces, ¿eso sí lo tiro? ¿Y la corona?
Thank you, Mike. In the left panel, you can see, again, we're inserting the implant through the guide, and you can see on the right side the position of the implants with their healing abutments relative to the guide. Here's the final case where we have 3 implants placed. This was an immediate, and these 2, and you can see the sinus graft, and the case has been restored. Our next case is implants in the upper right. This is a patient. You can see the patient's teeth are carious. They were extracted. The sites were grafted. We placed an immediate implant in the number 5 site, and now she was ready to have implants placed in the 3 and 4 sites. We used, again, same principle. The top, the 2 points of the trajectory are defined sequentially instead of all at once with a tube. We have a pilot hole guide and we have a thin layer guide. So the pilot hole guide is in place. We drill through to create our pilot holes. We then, in the bottom panel, you can see we're placing a drill through the guide hole centered to depth. At this point, we used a piezo surgery to perforate the sinus floor and place a graft. And we were able to do this flapless, which is a very nice thing for the patient since the morbidity is minimal. You can see the surgical analogs in place. The 2 implants had different buccal lingual trajectories, and you can see that in the upper right panel. And it was a flapless case, so we used a tissue punch. What I will sometimes do in a flapless case, given the anatomy of the ridge, the buccal lingual anatomy of the ridge, the shape of the ridge, sometimes if I were to use a punch up on this case, I might have taken out a little too much of the buccal tissue. It may have been thin there. So what I'll do is I'll just make an incision and loosen that a little bit and pull it back when I place the punch. And in that way, I don't take out that attached gingiva on the buccal. And in this case, we were able to use the punch through the guide. So here you can see the final drill, which approximates the size of the guide hole on the upper left panel. And this was a low-density case, and so the osteotomies were undersized. And I'm using the guide hole to center the implant driver because the implants can find their own way on insertion. The thing you have to be careful about in cases like this is angulation by operator-induced bias. So if I am not straight going into that osteotomy, I can allow that implant to self-tap in type 3 or 4 bone at an angle. On the bottom panel, I think you can see the position of the implants. And here's the finished case. And you can see the sinus graft that we had. And so this is what the patient looked like when they went home the day of surgery. This was a flapless sinus graft. We got about 11 millimeters in height. And on the lower right panel, you can see the finished prosthetic case. And for the prosthodontist, again, this was quite a simple restoration because the implants were placed in rather ideal positions.
What information would you need to receive for a fully edentulous upper case?
A fully edentulous upper case?
Yep.
For a fully edentulous upper case, it would depend as to whether it was going to be implant-borne prosthesis or an overdenture. If it were an overdenture, we would need a model of the edentulous arch and a cone beam scan of the arch. If it were a case where it was going to be implant-supported fixed bridge work, then we would need a scan of the patient wearing the denture and a scan of the denture.
Okay. Another question that came in is, essentially the dentist is receiving 2 surgical guides when they order surgical templates. Is that correct?
Yes. Each case we provide a tube guide and a thin layer guide.
Okay. I think we could proceed.
Again, our reasoning is this, is that when tube guides work, they're great. So if you have a case where you have vertical access for the tube guide, you're confident in your trajectory, you had a clean scan, then tube guides are great. It's just that you can't use tubes in a lot of places posteriorly. Or there might be other situations where you really want to be able to see what you're doing clearly. And even though you do have some visibility with the tubes that we provide, we have more visibility with the thin layer guides. It's even conceivable that someone could use, let's say on three implants placed, perhaps it's 2 bicuspids and a molar, it's possible that they would use the tube guide for the bicuspids. But because of the position of the molar and vertical clearance, they may not be able to use it on the molar. They could just slip in the thin layer guide and they're still in business.
But do you provide tube guides, or do you recommend thin layer guides in all situations?
No, we provide tube guides. We call them thin layer tube guides. You've seen some. I'll show you one in a minute. And we provide thin layer guides without tubes. We provide both in every case. So the dentist has there's a lot of flexibility with the system. So in a given system, in a given case, the surgeon can either use the tube guide and forget about the thin layer guide. They can use the thin layer guide and forget about the tube guide. Or they could use the thin layer guide and not use the drill stops and center it in the guide hole if they like the feel of freehand drilling, but they want to be guided. So there's a lot of flexibility. Or, as I said, in a given case, it's possible that you could have the bicuspids with tube guides and then the molar next to them because of lack of vertical clearance. You would then use the thin layer guide for the molar. So we try to provide a lot of flexibility to handle most situations a surgeon would run into.
Okay, great. I think we could proceed.
The last case we'll show is a lower first molar, and this is flapless. So again, first we go to Blue Sky Plan implant planning software. You get the cross-sectional, axial, panoramic view, and the 3D. It would size the abutment as a molar, 10 millimeters in this case, and use the abutment as a virtual tooth. In this case, we went to the cross-sectional view. We didn't have an opposing model, but we had a little piece of the opposing molar in the scan, and that enabled us to get some orientation toward the lingual cusp of that upper molar. You also can see faintly here the outline of the gingiva. So we have some sense of the depth of the gingiva over the implant. When you go into the 3D reconstruction, you can get an image, a 3D reconstruction of the patient's osseous anatomy. And if you toggle the density threshold, you can then get rid of the bone and see the roots of the tooth. And this is a very powerful tool. So you can see the relationship of your implant to adjacent roots. I might note that this menu here allows you to select a centered model, a model with markers, or the patient, or an articulated model, depending upon what has been scanned in. So you get this really enormous amount of enhanced aids for doing planning using Blue Sky Plan. So if you go to the 3D screen and you view model with markers, then you get the model with the marker indicating the ideal implant position. And then you can look at that and see if the center line of your implant is coming through the ideal insertion point. And you look at it from the buccal, you can look at it from the distal in order to get a sense of what your alignment is relative to the adjacent teeth. Then you can use the abutment as a virtual tooth. And then you do the case. And again, when we do the case, as review, we create a bleeding point. And that bleeding point is an insertion point analogous to the bottom of a tube. The thin layer guide that's placed at the occlusal surface level, that's analogous to the top of the guide tube. And together, sequentially, they define your implant trajectory. So we go in an angled entry. This is a first molar, and there were some vertical issues. Stand the drill up, go to depth. It was a flapless case, so we used a punch. Again, with each sequential drill, we did the same thing. Angled entry, stand it up, drop into depth, and you can see here the finished osteotomy with the guide hole from the thin layer guide. When you compare the tube guide to the thin layer guide, you can see the difference in that the stacking over here adds 7, 8, 9 millimeters vertical clearance. Here you go in at an angle, and you can see the relationship between the back of the handpiece and the teeth. Here we go in, and there's room to do it. Here, you have a problem. So when we take a look at the completed case, you can see the position of the osteotomy. The implant is placed through the guide hole, and if you look at the views on the bottom, you can see that this implant is placed in an ideal prosthetic position. I just want to make a couple other comments because I think we're pretty much finished with our presentation, Michael. But I just wanted to say that our goal is to make guided surgery a reliable and easy-to-use technology, which is readily available to the dental community. And I want to thank everyone for attending.